courtesy of the Ministry of Health. And for those of us who might not know what Ewene is, Ewene stands for Every Woman, Every Newborn, Everywhere. And this is a global initiative to aimed at ending preventable maternal and newborn deaths. In Kenya, we had the launch of the Ewene Acceleration Plan by the Ministry of Health. Of course, the president taking lead in this just to help accelerate the gains that we hope to make in ending preventable maternal deaths. Today, our topic is on antepartum hemorrhage, a team-based approach to maternal and neonatal survival. It's exciting because of how we've come together as a team to ensure that as we take care of our mothers, as we take care of our newborns, then it is not a one-man show. And all of us joining together, we are part of the team, and we hope we will feel that way as we move together. So as I said earlier, we have a great team of facilitators that will be taking us through this, and I hope at the right time we'll be able to introduce each and every one of them to make their presentation. It is now my pleasure to welcome Dr. Lois Nyanjau from the Ministry of Health to give her opening remarks so that we can kick off today's series. So Dr. Nyanjau, the floor is yours. Karibu sana.
Thank you, Dr. Odwor. Good evening, everyone. Good morning, good afternoon, in case you are in a different time zone. Welcome to this webinar series. I could not be more excited to be able to engage you, our colleagues, yet again, to address another difficult condition that claims our mothers and our newborns in the course of the reproductive health journey. So we really hope that we can deliver some lessons to colleagues. Where you find new information, please take it in. Where things are not clear, please relate to us by asking questions using the chat, the Q&A chat, the Q&A chat box. Or you can email your questions through the KNH webinar, and we'll be able to get that and respond to you. We have an entire team of experts, as Dr. Odur has told us, and we'll be responding to your questions almost in real time. We intend to do it as soon as we get the question, we respond to you. So let's keep our energies up. Karibuni sana. Here we are dealing with Ewene, as Dr. Odur has said, and we hope that once you get the lessons from this webinar, please pass it on to your colleague or your friend who was not able to join us today. Asanteni, and I'm looking forward to a very engaging evening. Back to you, Dr. Odur.
Thank you so much, Dr. Lois and the Ministry for having this together. As we start, just a reminder that some of the presentations that we are going to make and some materials will be shared at the end. So in case a slide escapes you, don't panic. The material will be shared with us. However, if it is something that is burning, as has been mentioned, you can put it in the chat box so that we are able to respond to it. As we start, allow me to welcome Nelson. We want to have a 5 or so minutes period where we just get to touch base on what do we know so far about antepartum hemorrhage. So we want to do a small quiz just to get where we are at for a few minutes, and then we go straight into the first presentation. So kindly, Nelson, take it up.
Right. Thank you, Dr. Dur, and welcome all participants to this session. On your screens right now, we have a small quiz that we would like you to attempt. There are a number of 15 questions, and you are welcome to answer them to the best of your knowledge. As announced by Dr. Awur, we will be sharing these resources and the correct answers and the guidance to these answers as well towards the end of this webinar. And also we will be posting a recording of this session and also the resources and the slides on that particular recording, so you can be able to get them. So for now, I wish to welcome all participants to attempt the poll that is currently displayed on your screens. If you're using your phone and you can't see it, kindly just swipe to the left or right, and you'll be able to see a poll displayed. If you cannot see it, at the bottom of your screen, there are some controls, and one of the controls should be polls and quizzes. If you can't see it there, kindly click on more. Those are the three dots. Once you click on that, polls and quizzes should be one of the options. So karibuni sana and attempt the questions we have for you.
So as we do the quiz, if you know of any colleague who wanted to attend and maybe have forgotten, maybe you can just buzz them and let them know that we are already on, so that they are able to join us in good time.
So keep them coming. We are receiving some responses. We will have about 5 to 6 minutes of this poll being on. So kindly just attempt. There is no wrong answer. As announced, we are just trying to get your grasping of APH. Asanteni for the responses. And also remember, you can let us know where you're joining us from through the chat section. And if you do have a question for the host or the panel that is with us here today, kindly channel it through the Q&A section. Please remember you can find these controls, or rather these icons, at the bottom of your screen.
Thank you. I see a lot of responses. Even I see people from all counties. As a member of Team Siaya County, watu wa Siaya nawaona, and I welcome all of you to the webinar for joining the rest of the country in learning together. I know usually there are those of us who are very fast, so when you amesha maliza number 15, you can just give us a thumbs up. You never know, maybe you may just win yourself a bar of chocolate that you will enjoy at the end of the webinar. Wonderful, wonderful. I don't know if Nelson will be able to see which was the first thumbs up, but there was a first thumb up somewhere. So Nelson, kazi itakuwa kwako kuniambia who was the first thumb up, so that they win themselves a bar of chocolate for today's webinar.
Doctor, it seems you have a lot of fast participants because the thumbs up are coming in, like really coming in.
All right. Beautiful. I think we are just ending. Nelson, do you think we can proceed or give them one more minute? I can see the thumbs up have really increased. So looks like most of us are getting to number 15, which is great.
Yes, we'll just give it a couple of minutes and a small grace period.
All right.
We can proceed with the webinar as the poll runs.
Okay.
Yes.
Thank you everyone for taking your time to answer. I think I just give them a few more seconds. We get to 6:45. The first presenter will be stepping on the floor. Good. So to start us off today, I want to introduce to us our first presenter. Our first presenter is Helen Odeny, an advanced nurse midwife practitioner from Kakamega County, and she will be taking us through a case presentation that highlights some aspects of being able to recognize APH early and to respond fast if we are to achieve our target of having our mothers and babies go home well. So allow me to welcome Helen. If you can share your presentation and take us through your case presentation.
Okay, good evening, everyone. I'm Helen Odeny. Thank you so much, Dr. Odwer. I think I also saw the first person who had a thumbs up. Okay, I'm Helen. I'm Helen Odeny. I'm an advanced nurse practitioner, midwife from Kakamega County. And here today, I'm going to share a case presentation from Kakamega County, and I wish to request Nelson to share it with us, and then we proceed.
Okay, just give me a moment. Apologies. Can you confirm if you can see my screen?
Yes, thank you so much. I can see it. And welcome once again, everybody. I think I've introduced myself. And so we'll be able to move to our next slide. So here we have a case of a patient by the name Li. She was 20 years old, a female. She was admitted, or she came to our facility on 3rd of April, that is this year, a para 1 plus 0 gravida 2, gestation of 41 weeks, with one previous care secondary to obstructed labor. So this client, next slide, she came to a level 3 facility accompanied by the husband. And she had a history of one previous care in 2019 due to obstructed labor. She attended 3 antenatal visits during this pregnancy, which she started at 28 weeks. Her antenatal profiles, VDRL was NR, HIV NR. Her blood group was B positive, urinalysis was NAD, and HB wasn't done due to lack of reagents. Next. Yeah. So history of presenting illness. On that very day at 5 a.m., she presented in a level 3 facility accompanied by the husband with the complaints of low abdominal pains, radiating to the back, and PV bleeding for 6 hours. She had a history of herbal medicine intake from a traditional birth attendant a day prior to the onset of symptoms. And when she came, she was alert on examination. She was pale 1+ with bilateral lower limb edema. Her vital signs were stable, except the pulse that was a little bit tachycardic of 110 beats per minute. And the fetal heart rate, yeah, it was the pulse that was 110 beats per minute. The rest were normal. Next. Yeah, so this year's was 15/15. Or other systems were normal. Per abdomen, Fundal height was 39 weeks. Cephalic presenting, lie was longitudinal. The abdomen was tender on palpation and the descent was 3/5. She had very strong contractions, 3 in 10 minutes, lasting 40 to 45 seconds. And the fetal heart rate, by then, it was a little bit bradycardic. On speculum exam, the cervical os was open with fresh blood pooling on the posterior fornix. An impression of APH was made at the level 3 facility. A plan to refer her to a level 5 was made, and she was to go for abdominal ultrasound, emergency CS, and continuity of care. So the team informed the family on the need of referral, and they initiated referral process where they called for the ambulance and the receiving facility. NASG was applied successfully, and tranexamic acid was administered 1 gram IV. The mother was catheterized, and the 2 large bore cannulas was inserted with normal saline running well. And then the mother was taken to level 5 facility. So next, so they arrived at level 5 at 7 a.m. That is around 2 hours. And then at that place, she went in a company of the husband and the nurse from the referring facility. On examination, she was sick looking by then, clinically pale, no jaundice, she had bilateral lower limb edema, no dehydration, no finger clubbing, and she was not in any respiratory distress. She was still complaining of severe lower abdominal pains radiating to the back, with obvious blood now flowing to the thighs with fully soaked cotton. Her hemodynamics, BP was 100/70, pulse was 118, a little bit higher from when she was in the level 3. Her temperature was normal, and the SpO2 was also normal in room air. She had a respiration of 18, and fetal heart was now 102 beats per minute. Next. So after that, on palpation, the fundal height was term, lie longitudinal, cephalic presenting, descent 3/5, GCS 15/15, other systems were normal on examination. Next. Yeah, so the plan was an urgent ultrasound, and the patient was to be prepared for emergency CS, do full hemogram, GXM. Theater was informed, blood was availed, consent, she consented because she was still conscious. And then she was given 1.5 liters of NS. The plan was also to monitor fetal heart, monitor vital signs, and also inform the relatives, which was done. Next. So 20 minutes after she arrived at level 5, the ultrasound was done, and there was placenta abruption. The mother was taken to theater. Emergency CS was done under GA. Her results for the HB was 5.8, and the team went in. Our anesthesiologist was present. The intraoperative findings were incongruent with the ultrasound finding, which showed there was placenta abruption. And a live female infant in cephalic presentation, birth weight 38 grams, was excited with an APGAR score of 2 in 1, 2 in 5, and 4 in 10. So this baby was resuscitated accordingly, and after like 15 minutes, the baby was taken to NBU for continuity of care on oxygen via nasal prong. Next. So during intra-op, there was uterine atony that was noted. Estimated blood loss was 1050. And at that time, oxytocin was administered, village sutures were placed, misoprostol 800 micrograms were administered, tranexamic again was given. And at that time, hemostasis seemed to be achieved, but she had some gross frank hematuria, which was suggestive of a bladder injury. So the plan was that the catheter she had was to be removed after 14 days. So the mother was taken to PACU, at 750, though unstable, NSG was also applied. Next. Yeah, so at 8:05, when she was still at PACU, her level of consciousness reduced with some oral secretion. On examination, she was now very sick, pale plus, vital signs. She was hypotensive, 99/57, SpO2 of 94 room air. Pulse were high at 133, and temperature was 36. GCS was now at 8/15. And per abdomen, it was soft, and the fundus was at 20 weeks, no distension, no tenderness. There was just minimal PV lochia loss. Urine output was 50 mils, which was blood stained. Next. So we can, so an impression of hypovolemic shock in a patient of day 0 post-emergency CS secondary to placenta abrasion was made. And again, the plan here was to change the catheter and to monitor input-output, uterine massage, run normal saline, Ringer's lactate, and we were to transfuse packed red blood cells. And also 1 unit of fresh frozen plasma. Renal challenge with 40 milligrams of IV Lasix, LFTs and UECs were done. And the mother was to be admitted in HDU for close monitoring, and she was taken to HDU at 8:50, at least to continue with the management and close monitoring. Next. So remember, this is the mother who came at 7, and by midday, 1:15 midday, the same day in HDU, she developed sudden cardiac arrest, and emergency response teams were informed. CPR commenced, which was successful. But thereafter, she was put on ventilator at the in the HDU. Urgent abdominopelvic scan was done by the bedside, and there were free fluid in paracolic gutters that were noted. And the decision for an urgent XLAP was made. Relatives were informed and counseled about the procedure, and they consented. XLAP was done in the HDU bed, with a whole team of obstetrics, surgical, nursing, and the theater, the ICU team. They were on board. Next. Thereafter, during that procedure, uterine atony was again noted, bladder injury with a defect of 6 cm noted, and moderate intraperitoneal bleed noted. So TAH was done, bladder repair with Brickril in double layers was done. Post-surgery, the patient's condition improved drastically. Vital signs improved. BP now was 107/67. Pulse still 110, but it improved. SpO2 100 on ventilator. And the plan was to keep the patient in STU for close monitoring. Next. So she recovered in ICU for like 3 days, and then she was stepped down to postnatal ward on the 4th day, where she continued with her recovery process, and later was discharged home on 4th May 2026. Yes, next. So what's our take-home message today is that every APH is an emergency until proven otherwise. When you see any mother with a vaginal bleeding after fetal viability, this requires an immediate assessment and action. 2, first, we need to stabilize and refer. So it's always important to assess the airway, breathing, circulation, access, IV access, fluids, and monitor vital signs and avoid delay of referral. 3, do not perform a digital examination when the mother is having PV bleeding. 4, next. Yeah, next. 4. Always early recognition saves lives. So prompt identification of bleeding, shock, and fetal compromise improves outcome. It's always important to communicate before transfer, and normally we use SBA. So call the receiving facility and provide a clear handover and document the findings and intervention. Refer with an escort and monitor whenever possible. It's important to ensure that the woman is accompanied by a skilled health worker and referral notes. Next. Always ensure that the blood is available in such critical situation. When you anticipate transfusion, there is a need to avail the blood. 8 is that RMC should be taken care of when taking care of our mothers during emergencies. Keep the woman and the family informed all through, work with them and support them. Finally, strong referral system saves recognition, stabilization, communication, transport, and definitive care are very important in saving lives of our mothers and babies. Finally, next. So in conclusion, in summary, we can say that effective management of APH requires early recognition, prompt stabilization, effective communication, and we need to refer without any delay. Every minute counts in APH. Thank you so much, and back to you, Dr. Odur.
Thank you so much, Helen, for that wonderful presentation. Much appreciated. A case that really illustrates the good things that can happen when we recognize APH early and respond fast. Now we want to dive into some deep aspects of managing a patient who is presenting with antepartum hemorrhage. And I want to welcome our next presenter. Our next presenter is Dr. Grace Wanjiku. Dr. Grace Wanjiku is an obstetrician gynecologist, currently working in Murang'a County Referral Hospital. Dr. Wanjiku is very passionate about Ewene. If you are to have a passionometer of measuring how passionate she is, I think probably it might get to the end of the scale. And it is my pleasure now to welcome Daktari to just dive deep into specific aspects of management of a patient with APH. Karibu Daktari.
Thank you so much, Dr. Odur. Please confirm that you can hear me.
Yes, we can hear you and see your presentation as well. Proceed.
Wonderful. Thank you so much. As I've been introduced, my name is Dr. Grace Wanjiku, working in Murang'a County Referral Hospital as an obstetrician gynecologist. And I would like to take us through this presentation on clinical management of antepartum hemorrhage. It is quite a wide topic, and I wish we had more time to delve into it. So most likely we are just going to go through it in a brief manner, and that is the outline of my presentation. So to start with the definition of antepartum hemorrhage, it is basically defined as bleeding from or into the genital tract occurring after 24 weeks of gestation, which is considered the gestation of viability, and which is unrelated to labor and birth. So that is bleeding in pregnancy that occurs before the baby is born. So it is considered to actually be about the third direct cause of maternal mortality, because most of the times it is also associated with postpartum hemorrhage. It is said to affect about 3 to 3.5% of pregnancies, of all pregnancies. It can be categorized as either minor, major, or massive APH, depending on the amount of bleeding that has occurred. So causes of APH, most of us are familiar with these causes, and these are cases that we have managed. The commonest is placenta abruptio, which is said to account for about 30% of all causes of antepartum hemorrhage. Then you have placenta previa coming in second at about 20%. You have uterine rupture, which is generally it's supposed to be rare, but it is more common than reported. We also have what we call vasa previa, which we will look at later. It is also said to be rare, but I think it is rare because our diagnostic capability is wanting, and it requires proper radiological diagnosis for us to say we have vasa previa. We also have cervical lesions, vaginal lesions, and sometimes you can't actually identify the cause of the antepartum hemorrhage. So some of the risk factors for antepartum hemorrhage include previous placenta previa. If a mother has had previous history of placenta previa, which we will look at what that is. a previous cesarean section, meaning they have lower uterine scar, multiple gestation trauma. Trauma is a common cause of antepartum hemorrhage. Previous uterine surgical interventions, for example, manual vacuum aspiration for management of abortion, dilatation and curettage, either for management of abortion or hydatidiform mole or uterine synecdoche, myomectomy, or any uterine surgical intervention for congenital anomalies or such procedures. Others include increased parity, increasing maternal age, fertility treatment, maternal smoking and cocaine use, which may not be very common in our setup, prior uterine artery embolization, which is mostly or commonly used for management of fibroids, and also endometriosis. So we can look at a few of the common causes, which is placenta previa, placenta abruptio, and vasa previa. Placenta previa refers to the implantation of the placenta over or near the internal os of the cervix, which is basically the lower uterine segment. And it can be classified as either type 1, type 2, type 3, or type 4. I think most of us are familiar with this classification. Type 1 is where the placenta approaches the lower segment, does not reach the internal os. Type 2 is where the placenta reaches the margin of the internal os, but does not cover it. Type 3 is placenta partially covering the internal os, and type 4 is where you have the complete coverage of the internal os. We will delve deeper into how to diagnose this because you need an ultrasound for you to be able to determine which type of placenta previa you're dealing with. So this is just an image showing the different types of what you would expect to see when you're doing radiological diagnosis of placenta previa. So just a brief on the management of placenta previa. Basically, it will present as painless pervaginal bleeding after the gestational viability. Initially, we used to consider it at 28 weeks, but now because of our improved ability to take care of smaller babies, it has been lowered to about 24 weeks in better centers. And it will present as bright red bleeding with no uterine pain or no lower abdominal pain. And a speculum exam is required for you to be able to rule out other causes of the PV bleeding. And the diagnosis is usually confirmed by an ultrasound. So depending on how the patient presents, if the bleeding is heavy, continuous, and there's hemodynamic instability, like the case that Helen has so ably presented for us, then you probably want to deliver that mother via cesarean section. And when we talk about hemodynamic instability, you are looking at the vital signs and the clinical presentation of the mother. Where the mother presents with some light bleeding that starts and stops, most of the times is usually minor bleeding. The mother will present and say she probably has changed 1 or 2 pads. The mother is hemodynamically stable, meaning the vital signs are within the normal ranges, and the mother is not showing any clinical signs of shock. Then you want to, in this mother, consider or look at the fact that whether the fetus is premature or the fetus is mature. So in cases where this presents in the preterm stage or the preterm gestation, you probably want to buy some time and optimize the fetus. And by optimizing, you want to admit the mother, correct for anemia if it is present, and meaning you will have to do some laboratory tests for you to be able to determine that. And then you want to administer antenatal corticosteroids, and these are usually to be able to quicken lung maturity for a preterm baby. And you plan for eventualities of emergency delivery if bleeding persists or if massive bleeding occurs. So if you have a fetus who is mature, meaning the baby is 37, 38, 39 weeks, you probably want to assess at the time of presentation, depending on the type of placenta previa. If it is type 1 or type 2, type 2A, there's a type 2 that you can consider delivering vaginally. Then you want to do your assessment and determine which is the safest mode of delivery for this mother. Most of the times, we end up doing elective cesarean sections for these mothers. So for placenta abruptio, this is basically refers to premature separation of a normally implanted placenta from the uterus before delivery of the fetus. We know that physiologically, the normal physiology requires that the baby is born first, and then you have the separation of the placenta, because we know the importance of the placenta. So an abruptio is where you have this separation happening before delivery of the baby. It is said to occur in about 1 to 2% of all pregnancies, and it is basically a cause of about 5.1% of preterm deliveries. It can generally be classified as either revealed or concealed. Revealed is where you have the amount of visible blood loss being commensurate with the level of shock. So if a mother comes and says, I have been bleeding for the last 1 hour, I'm feeling dizzy, you take the vital signs and, you know, there's some element of instability, she's looking pale. And when you look at the amount of blood that she has bled, it seems to tie with her clinical status. You also have abruptio placenta, which is sometimes concealed, where the amount of external blood loss is disproportionate with the features of anemia or shock that the patient presents with. So the patient presents with signs of shock, but when you interrogate and you examine and you look at the amount of bleeding that the patient has, it doesn't seem to tie with the amount of blood that she has lost. So this is basically, again, an illustration and an image from an ultrasound that would help us to understand how a placenta abruptio would present. On ultrasound imaging, our senior colleague is going to delve into that. So management of placenta abruptio, as we said, it will present with a history of either massive pervaginal bleeding or minimal pervaginal bleeding. But in this case, the mother will have history of abdominal pain. So after you've done your clinical diagnosis of placenta abruptio, in these cases, most of the times you end up having emergency delivery in most of the cases that we have seen. So if the mother presents with heavy bleeding, hemodynamic instability, especially in concealed type of placenta abruptio, you want to assess and see, is the mother is the cervix dilated? Can it allow for vaginal delivery safely, either both for the mother and for the baby? And in this case, you want to have an expedited vaginal delivery where you have assisted vaginal delivery to be able to get that baby out as quickly as possible. So if the cervix is not fully dilated, then you want to do an emergency cesarean section. For mothers who present with some light, moderate bleeding, they're hemodynamically stable, but you have done your assessment, you've done your ultrasound, it is showing the separation of the placenta, but the baby, the fetal heart rate is either is normal. Let us start with a normal fetal heart rate. If the mother is in labor, because sometimes the mothers will present in labor, you want to expedite this delivery. You want to augment that. We are considering this, for example, for a mother who presents at term. If the cervix is unfavorable, meaning the cervix is not anywhere near showing signs of being in labor, has a poor Bishop score, then this is a mother you want to deliver via cesarean section. If the fetal heart rate is absent, and the mother is hemodynamically stable, meaning you're most likely having an intrauterine fetal death. So this is a mother you would prefer to deliver vaginally, because in cases where you have an absent fetal heart rate, it most likely means that either the separation is complete, or the separation is so big, the surface of the separation is so big that it has completely separated the maternal fetal circulation. And if you end up doing a cesarean section in such a mother, you are likely to end up with coagulation issues, because the massive separation of the placenta, remember the placenta has receives circulation from huge vessels from the maternal circulation, meaning if you have had a huge bleed, most likely they have consumed most of the coagulation factors and the platelets. So in cases where you have an abnormal fetal heart rate, meaning you have fetal instability of an unreassuring fetal status, you want to do, depending on the assessment of the cervix, either a rapid vaginal delivery if no contraindications exist, or an emergency cesarean section. So this is a table showing the differences between placenta previa and placenta abruptio. Again, as we were starting the webinar, we said that this presentation will be shared. I do not want to delve deep into this, so I think it's quite self-explanatory and all of us are able to go through it. It's quite clear. So for vasa previa, this one is rare, and I think it is rare because our investigative capability is usually limited when it comes to vasa previa, and most of the times it's usually on just suspicion on clinical assessment. So the prevalence is said to range between 1 in 1,200 to 1 in 1,500 pregnancies. Most of the times it's underreported. It is caused by aberrant and protected vessels tracking along the membranes running across the cervix. And it will present with pervaginal bleeding that causes fetal distress after the rupture of membranes. You can have a type 1 or type 2. You can diagnose it clinically when you find pulsating vessels at the internal os, when you do your vaginal examination, and you will find dark red vaginal bleeding with acute fetal compromise. Most of the times it will be bradycardia. The management here is just a cesarean delivery. Otherwise, you're going to lose that baby. So this is again just an image showing the different types of vasa previa and how it can occur. So how do we approach management of antepartum hemorrhage? I think Helen has done a good job in laying the foundation when it comes to this, but I would like to approach it by considering several factors when a mother presents with antepartum hemorrhage. One, you want to look at the maternal status. What is the hemodynamic status of the mother? Are they stable or are they hemodynamically unstable? Then it will tell you the kind of speed of response that you want to, and the kind of response you want to give to this mother. What is the fetal status at presentation? Is it reassuring or non-reassuring? Is it at term or a preterm baby? What is the capability or the capacity of the facility to handle antepartum hemorrhage and any following complications that may arise from the antepartum hemorrhage? Availability of theatre services, ability to transfuse blood, and neonatal care capacity, especially when you're dealing with preterm pregnancies. We've talked about gestation at the time of presentation. So if you're in a lower level facility, again, going back to the case that Helen has ably presented for us, after your initial assessment and stabilization of the mother, you've done your maternal and fetal status assessment. You want to assess for the urgency of referral. And you want to inform the referring facility using the ESBA principle. Helen mentioned the ESBA principle. And ESBA is basically an acronym that we use when we are communicating. It is for to be able to communicate with the referral facility clearly on what you have, your assessment. So you want to report on the situation on the ground. You want to report on the background. So the situation, you'll probably call and say, this is this facility X. I am calling to refer patient LI para 1+0 gravida 2. The background is that she's at 41 weeks, one previous scar, and she has presented with pervaginal bleeding. The assessment is the fact that on examination, she has a tachycardia, the blood pressure is low, and there is active bleeding, PV. And our recommendation is we want to refer for immediate delivery and stabilization of the mother. So ESBA is very important when you're communicating with the referring facility because it enables the facility to prepare for the patient who is coming in and also to be able to make their own assessment and advice on how to treat the mother en route, because the referral is also supposed to be, there's supposed to be continuation of care as the mother is being referred from one facility to another. So in a higher level facility, a level 4 or level 5 facility, if the mother has presented, you have done your assessment and the maternal status is the fact that there is hemodynamic instability or fetal instability, non-reassuring fetal status. So, for example, in maternal shock, this is not a mother you want to manage alone. You want to shout for help. You want to assess for your ABCs, your airway, breathing, and circulation. You quickly want to get or have access, IV access with 2 large bore IV cannulas. Helen again mentioned this in her case presentation. You want to collect blood for grouping, cross-matching, a full blood count, UECs and coagulation if your lab is able to do them. And you want to quickly start your resuscitation with IV fluids, tranexamic acid as you wait for blood. Then, if you have a POCUS or the ability to do a quick fetal assessment, you want to do an emergency obstetric ultrasound, and the delivery here should be the safest and quickest mode for the mother and the baby. So in this case, you want to assess and see whether you want to do an emergency cesarean section or a vaginal delivery. Most of the times in maternal shock, you probably want to do an emergency cesarean section. So when the mother presents and they're stable, the fetus is okay, then you want to admit, do your baseline blood works, which include grouping, cross-matching, a full hemogram, UECs, coagulation profile if you have the ability to do it. Then depending on the gestation, you want to assess and see if it is a baby who presents or a fetus who presents between the gestation of 26 to 34 weeks, you want to give corticosteroids to help with lung maturity. And for lower gestations, 26 to around 32 weeks, then you probably want to consider magnesium sulfate for neuroprotection. So this depends on the gestation. You want to do close monitoring of the vital signs of the mother. And by close monitoring of the vital signs are very, very important. And one of the most important ones is the pulse. If the pulse is changing, and most of the times in bleeding, maternal bleeding, it will tend to first go up. By the time you're having the pulse going down, then you are in the danger zone. So if you're starting to get a tachycardia, you probably need to reassess your situation and consider delivery immediately. So you want to do close monitoring of vital signs and assessment of pervaginal bleeding if it is continuing. So for mothers that we admit, let me mention something about the grouping and cross-matching. The grouping and cross-matching, you want to do what we call grouping and cross-matching and saving. So you need to liaise with your laboratory and inform them that you have a mother who is currently stable but is likely to have either massive bleeding or is likely to require blood when you go in to deliver. So you also, in such cases, want to plan for delivery at the safest time for the baby and the mother. This definitely requires multidisciplinary team approach, where you need the theater team on the table, anesthesia team, the neonatal team, and your laboratory team. So what are the complications of antepartum hemorrhage? We can divide them into maternal complications and fetal complications. I think the case that Helen has so excellently presented for us has brought out all these complications that we are seeing here. One, anemia, postpartum hemorrhage with the risk of hysterectomy. That patient got that. Risk of infection and sepsis, maternal shock arising from hypovolemic shock or septic shock, acute kidney injury, which may follow into chronic kidney injury, consumptive coagulopathy because of the massive bleeding, and this is common in massive bleeding in placenta abruptio, prolonged hospital stays, ICU admissions, psychological sequelae, both for the mother, the family, and the healthcare workers, because most of these cases tend to be quite traumatic to everybody involved. And also we need to consider complications of blood transfusion and massive transfusion, because most of the times we end up having massive transfusion, and blood transfusion tends to come with its own complications. So for fetal complications, and for this we have a wonderful neonatologist who will take us through, but just briefly, you may end up with the small for gestational age babies, prematurity with all the complications that come with prematurity, fetal hypoxia, and in the worst case scenarios, you may end up losing the baby. So how can we prevent antepartum hemorrhage and the major adverse outcomes that arise from antepartum hemorrhage? One, right from the community, prevention of unwanted pregnancies by ensuring that there is access to quality, accessible family planning services. Antenatally, when the pregnancy has already happened, you want to prevent and have timely management of anemia of pregnancy and timely and quality ultrasound screening of our mothers, especially the high-risk mothers that we have mentioned before. Public education of pregnant mothers and the community at large on danger signs and patient self-advocacy when it comes to bleeding in pregnancy. Investment in a robust referral system, as Helen again mentioned, the infrastructure and the personnel is very, very important, and most importantly, adequate preparedness in our facilities to handle APH and any complication arising from APH like PPH, and also access to critical care services, like the case that Helen again has presented to us. So in conclusion, as the old adage goes, prevention is always better than cure. So if we can prevent that primary cesarean section, it would be very important, because like for placenta previa and any complications of placental adherence, like morbidly adherent placenta, if you can prevent that primary cesarean section by adequate monitoring of our mothers during labor, adequate assessment, so that we only do cesarean sections for the mothers who deserve or whose indication is strong enough, then this would go a long way in preventing APH in future. Emergency preparedness in our facilities cannot be overemphasized. A functional referral system is the cornerstone of management of APH and its complications, and multidisciplinary management is paramount. So those are some of the references I used in my presentation. Thank you very much. Back to you, Dr. Udwar.
Thank you so much, Dr. Grace. That was a wonderful presentation. I know there's been a lot of learning there. If you feel Daktari may have gone over slide a little faster than you wanted, fear not. As Nelson said earlier, all this will be shared so that you're able to revise as you remember what Daktari has taken us through. Asante sana, Daktari. Now, I want us to welcome our next facilitator, and our next facilitator is going Hello, I hope I'm back.
Yes, you
Apologies. Apologies, Kenya Powers decided to do that bad things, but my backup is up and running for the internet. Sorry for the interruption. So our next presenter is going to dive us into a little more aspects of imaging. As Daktari has presented, one of the things that is key in terms of diagnosis is you need quality imaging services to be able to make the diagnosis of what is causing the bleeding. So allow me to introduce Dr. Mutindi Kakuti. Dr. Mutindi Kakuti is an obstetrician gynecologist and a maternal fetal medicine specialist, basically to say that she specializes in high-risk pregnancies. And nothing can be more high risk than a pregnant woman who is bleeding. And so this evening, it is my pleasure to welcome Dr. Kakuti to just take us through imaging, in-depth discussion into the role of imaging in making a diagnosis and management of a patient with antepartum hemorrhage. Daktari, karibu.
Thank you very much. I hope I am audible.
Yes, we can hear you and we can see your presentation as well.
Thank you very much. I want to thank the presenters who have gone before me and just an amazing recap of the management and how to make a diagnosis of patients who have APH and the case that was presented. And so today I want to discuss the ultrasound pulse of antepartum hemorrhage. What are the perspectives from maternal fetal medicine in terms of imaging? And so when we do an ultrasound, there's something I call a walkabout. So those who are more university students or as residents know that I teach something called a walkabout, and I learned this from the person who taught me. And what are the basics of point of care ultrasound, which I think are very important, which is a very important aspect of obstetrics, which is not limited to doctors, but also to nurses and anyone working in a maternity center or a labor delivery unit. And a walkabout is basically where you're taking a walk around the mother's abdomen and asking myself, what am I looking for? What are the important things? And there are 5 important things you want to start looking at. And you want to ask yourself, is there viability? What is the presentation of the baby? And we want to locate the placenta, the number of babies, as well as looking at the adequacy of LICWA. And this is something that every person working in an L&D, that is labor and delivery unit or maternity department should be able to know. And so a walkabout is basically taking your ultrasound probe and doing like a zigzag walk, either up or down. So you're going right from the right left iliac fossa and doing a zigzag up to the fundus of the mother and coming down, up to the, I would say up to the xiphisternum and coming up and down in zigzag pattern, or you can go up and down or sideways up to the top. And so you're able to ask yourselves and answer the questions of viability, presentation, location of placenta, number of fetus, and adequacy of LICWA. So I will not go into the details of what Dr. Njoki has spoken about, but I will just want to clarify that the old classification of placenta previa grade 1 to 4 is not used anymore because of very huge inter-observer inconsistencies in making the diagnosis. And so we have advancements in ultrasound, and especially transvaginal ultrasound. And so we use that as a gold standard for making a diagnosis of placenta previa. MRI may be used, but it's not absolutely necessary. I think a TBS is quite amazing. So this is something which we hope every also maternity department should be able to have somebody in the department who can do a transvaginal scan, or at least the radiologist or radiographers. So you have two classifications. You have complete previa and low-lying placenta. And complete previa, you have the placenta completely covering the internal os, and a low-lying placenta that is within 2 centimeters. The edge of the placenta is within 2 centimeters of the cervical internal os. So we don't use the old classification anymore. Sorry, Dr. Njoki, I don't know if I busted your bubble, but he did a great job. So we talk about something called placental trophotropism. And that is where the placenta grows into a particular part of the uterus whereby there is the highest blood supply. And so there's a bit of growth shift as the uterus grows, and there's a change in location to the placenta, which we call migration. And so due to this placental trophotropism, a diagnosis of placenta previa cannot be made before 20 weeks. Some authorities use 16 weeks. And you want to make this diagnosis definitely at 32 weeks due to the formation of the lower segment of the uterus. Now, almost every obstetrician, every doctor has gotten a scan saying low-lying placenta, and the radiologist or radiographer will say, "Hey, you need to see the doctor very quickly. This is something, there's something wrong with your baby or something wrong with your placenta." But I think for those of us who have followed up on patients in our clinics, we know that in majority of cases, when you see a low-lying placenta in the second trimester, there's a very high likelihood that this resolution that will occur with development of the lower uterine segment by around 32 weeks. But we are saying that a definite diagnosis of placenta previa is made at 32 weeks, and transvaginal scan is the gold standard of making this diagnosis. So when you're doing a transvaginal ultrasound, you are not doing you're going from the abdomen. Of course, you must do a transabdominal ultrasound as well as a TBS. And you want to cancel the patient on the route of scanning. You are going to be invading quote unquote our privacy. So you want to explain to the patient there must be an empty bladder. You want to identify this placenta. Is it anterior or posterior? And for those of us who are surgeons, we know that as you go in, you do not want to open the uterus and encounter an anterior placenta that you are not ready for. So if you know that in advance, then you may want to make your incision elsewhere. And then you want to obtain sagittal views. Color Doppler should be also implemented, especially at the cervical os, because of the association of a placenta previa with the subcentriate lobe and velamentous cord insertion, as well as vasa previa that Dr. Njoki has spoken about. You also want to look out for focal myometrial contractions, because they tend to appear, they may have the same echogenicity as that of the placenta, and so you may get confused. So when you see one, it's like you look at the continuity of the myometrium and you see something bulging out, and you want to say, let me just continue doing my scan and then come back to it later. If it has disappeared, then likely it is a focal myometrial contraction. Sorry for that noise. And then you want to look at the characteristics of the placental agency where it is lying. So these are a few images. The first image, I don't know if you can see my arrow. Is it possible to see it and see me moving? So when you see the top of your image looking like this, and that is a transvaginal scan. So the first and the third images, you see that you are looking like that, like something that was supposed to be round and being cut off. That's a transvaginal ultrasound. And what ideally you should look for is look for the cervix, look at the cervical canal, and then you can see the placenta, a hyperechoic structure or tissue lying right on top of the cervical canal, and that's a complete previa. Now, this is a transabdominal. The middle image is a transabdominal ultrasound, whereby also there you can see the cervical canal, and then you can see the hyperechoic placenta lying right on top of the cervical canal. All right. And then in the third picture, which is a transvaginal scan, you can see the cervical canal and then the edge of the placenta here. So that's a low-lying placenta, not complete previa, but a low-lying placenta. But if you're to measure and it's less than 2 centimeters from the cervical os, and that is a low-lying placenta, and we don't use the other gradings. Then we come to placenta abruptio, and I think Dr. Njoki has spoken very well about this. That it's really, really, you need a high index of suspicion, primarily a clinical rather than an imaging diagnosis, relying heavily on symptomatology of painful vaginal bleeding. And we know that for previous, she said, is that there is painless vaginal bleeding. So ultrasound usually has a low sensitivity of between 23 and 57%, cannot be really used to rule it out, but it has a high specificity. And with advances, of course, with ultrasound resolution, then of course the sensitivity is getting better than what was reported before. And then ultrasound, of course, remains vital in making an assessment for fetal well-being. We know patients who have abruptio, you may even have a mother who is, having maybe a antepartum hemorrhage, but may be stable, but the baby may not be stable. So the ultrasound findings will depend on the time that has passed between the bleeding began, because there's a difference in the echogenicity. And that is, when we talk about echogenities, how do tissues appear on ultrasound? So, if it's white, the whiter it is, the more hypoechoic it is. The darker it is, looking like there's a urine in the blood, the more it's called hypoechoic. So if it is a fresh bleed, it's likely to be more hypoechoic, and if the bleeding has been there for a long time and the clots have resolved, then you may get a hypoechoic looking area behind the uterus. And then, of course, the size of the bleed also may help you make a diagnosis of placental abruption. But really, we want people to rely more on clinical acumen. And so what are the ultrasound findings? As you might see, a retroplacental hematoma, a blood clot that lies between the placenta and the uterine wall, an acute bleed, as I've said, tends to appear more hypoechoic. It's brighter or isoechoic to the placenta. It may even look like the placenta tissue itself. So we talk about isoechoic is something appearing like something else. So that bleed or that clot that is acute may appear like the placenta itself. Then you might find thickening of the myometrium. They say it should be around 1 to 2 centimeters, unless there is a focal myometrial contraction. The placenta may appear thickened due to the underlying hematoma and measuring more than 5.5 centimeters, and there may be an intraamniotic hematoma. Now, the other thing is, you may notice this, I've never seen it, but I just saw it somewhere on literature, is that there might be some like jelly-like motion of the hematoma with fetal movements or movement of the probe. Now, I'm not recommending that you move the probe and try and jiggle the clot. You might provoke bleeding. And then you might see that the placental edge is rounding off. Usually it has a triangular end. As the edge, as you look at the edge of the placenta, it has a triangular taper, it tapers off. But then you may see rounding off of the placental edge because it's lifted up. Then you want to assess fetal well-being. You want to look at the Dopplers. And normally when we look at the fetal stomach, usually it is, you just see a stomach bubble. But if it's looking like there's something else inside, because if there's blood in the amniotic fluid and the baby is swallowing this blood, then you might see a hypoechoic fluid in the more than normal, what the stomach would look like due to amniotic fluid that has blood in the fetal stomach. Then you may have intermembranous clot where you may have twin gestation. So a lot of these things I'm British, I've not seen them myself personally. So when we look at the limitations and diagnostic pitfalls, and that's why I'm saying you need to heavily rely on your clinical acumen, is that there's a high false negative rate, and up to 75% of confirmed abruptions are missed on initial ultrasound because acute bleeding blends with the echogenicity of the placenta. And with revealed bleeding, you may not see a clot or hematoma between the uterine wall and the placenta. MRI may be superior, but high clinical index of suspicion is advocated. And the ultrasound findings again may also be missed, whereby you have a very maybe negative with very early abruption or when it's very mild. So when we look at the imaging, you can see in the first image you have placental abruption. That's a transabdominal scan, and you can see the difference between this image, whereby you have the placenta, the hypoechoic tissue, you have this bright line here, that's the fetal head, and then behind and then there's a line along here whereby you have the myometrium, and then you have a luteroplacental bleed or hematoma behind here. And here you have intraamniotic hemorrhage, whereby you have bleeding from placental abruption, and then you have some bleeding into the amniotic fluid, and then here you have a concealed abruption. And because you can see the placenta here, fetal parts at the bottom, but you can see here that this is very compared to the first one, this is hypoechoic because maybe the bleeding has been there for a while and the clots are resolved. So we look at vasoprevia. Dr. Njoki has ably given a definition that they are aberrant vessels that cross the internal os or are in close proximity to the internal cervical os. And I say during the walkabout, please identify if there are any fetal vessels with a color Doppler that are crossing the cervical os or in close proximity to the internal os. So when you're doing your walkabout, come to the presenting part, identify where your cervix is and where the fetal, the presenting part is, and then put a color Doppler. You just put the box there and see if there are any vessels or any color that will be taken up by the ultrasound. You want to look at the fetal, and also this the vessels may also precede the presenting fetal part. There are two types. You have 90%. Type 1 is whereby 90% of abnormal vessels connect to a velamentous cord insertion with the main body of the placenta, and then you may have type 2 whereby you have abnormal vessels that are connected to a biloplacenta or with a subcenturate lobe. So it needs, so in all patients who have variant placental morphology, that's vasoprev, that is subcenturate lobe or biloplacenta, or you have velamentous cord, then you must rule out vasoprevia, and ultrasound is 90% specific. Now, a systematic review revealed that 98% of those are 98% survival rate of neonates when vasoprevia was diagnosed prenatally. And if undiagnosed, then there's a 25-fold increase in perinatal mortality. So question is, the screening of vasoprevia is controversial because it's considered to be uncommon. I think in my 24 years of working, I have only seen one. So yes, they are rare, but I think you do not want to miss one. So is it feasible to screen? Absolutely yes, when you're doing your ultrasound. So the ultrasound findings would be with an transabdominal scan. You want to put your color Doppler, and it will show flow within the vessels that overlie the internal cervical os. And then you have distinct linear or circular blood vessels crossing the membranes near the cervical os. If you're using 2D or grayscale in case your color box isn't working. And then you want to do a spectral Doppler that confirms that the vessels are fetal. A transvaginal scan is not absolutely contraindicated because the sensitivity is very high, 100%, and when you use a color Doppler. So screening should be done during between the 18 and 22 weeks when you're doing your anatomy scan, and visualizing a velamentous cord insertion, that is our umbilical cord that inserts into the fetal membranes rather than directly into the placenta or low-lying placenta should trigger evaluation for vasoprevia. So when we look at these images, the first image you can see and this looks like a transvaginal scan, and you can see where the cervix is like. You can see their vessels, you can see the presenting part, and their vessels preceding the presenting part. So when you put your color box, then you're going to see flow, and you want to put your spectral Doppler to confirm that those are fetal vessels. The other thing is when you look at the also in the second image, you can see where the placenta is lying, and you can see that they're fetal vessels. These are velamentous cord insertion. You can see fetal vessels inserting into the membranes, and they're very close to the cervix. So that should trigger a diagnosis of vasoprevia. Dr. Njoki has, I think, shown us an image of what a velamentous cord insertion looks like, and I think that's both images. These slides are going to be shared. And then so for example, should you not have a color Doppler, then if you're doing if you're doing your ultrasound and you're using just the grayscale, then you'll see what look like, when I'm teaching, I normally call them, they look like snakes in the fluid. And when you see them in 2D, then you put color, then you may see what the vessels, that they are fetal vessels, and we put spectral Doppler, then you see that. Another image here that shows us a velamentous cord insertion, and that should trigger evaluation for vasoprevia. Then we look at uterine rupture. This is whereby you have discontinuity or a defect in the uterine wall. And also when you're doing your ultrasound, the things you're going to find, I'm just going to go through this quickly, is the discontinuity or a defect in the uterine wall. There's hemaperitoneum or presence of fluid in the abdomen. You have an empty uterus with the fetus located outside the uterus, and that's a complete rupture. Color Doppler, you have increased, when you put your color Doppler, you have increased vascularity or bleeding at the rupture site. And then you find that the fetal position is abnormal. It's outside the uterine cavity. And when you're doing so the other question is whether should we be measuring third ultrasound, looking at the lower segment thickness, lower uterine segment thickness, should that be measured? And yes, when I get a previous patient who wants to try photolac, I do personally, and it's something I think not widely used. I think sometimes we use a lot of our, the scoring system more than the measurements to determine whether a patient can have a trial of scar with after cesarean delivery. So a thickened uterine wall, of course, a thicker uterine wall measuring more than 3.5 millimeters means a lower risk for scar tearing, and this usually should be done between 36 and 38 weeks, and usually transvaginal scan is preferred. And yes, if the thickness is more than 3.5 millimeters, then the risk of rupture is low. Although there is a relationship between the lower uterine segment thickness and risk of uterine rupture, the absolute cutoff usually, whether it is safe to tolerate a patient or not, usually remains uncertain. And in clinical practice, with those who have a thickness of less than 2 millimeters, then ideally should not attempt TOLAC. However, this recommendation is not mandatory. So for example, if you get a patient who has had a previous VBAC, so she's had an SVD and then maybe had a VBAC and then maybe had a cesarean section and maybe it has had a VBAC afterwards, and then you find the uterine thickness is maybe 2 millimeters or less, then your question is, should we try? Now, some may say you cannot try, but then again, I think when you look at the scoring system for whether you can try labor after cesarean section, then I think there are other clinical considerations, and that can help you to make a decision whether you can tolerate your patient or not. So when we look at the ultrasound findings, we can look at the first image. You can see the uterus here, and you can see the endometrium, the bright area, that's endometrium, and then you can see the baby is outside the uterus. Same with the second image, whereby you have the uterus, and then when you're walking around, you see the fetus is outside the uterus. And this is not something that that is easy. I think it's easy to think it's easy to find, but usually it's not easy to find. You have to be you have to get used to what do things look like normal when you're doing a scan, then you can be able to pick up the diagnosis of a uterine rupture. And then also you want to look at uterine dehiscence. This is a transabdominal scan looking at the way the probe is placed, and you can see fetal parts, the bladder is there, and you can see the uterine wall separating from the bladder, and that's uterine dehiscence. So that, of course, would be a danger sign for you to manage and monitor this mom. Thank you very much.
Thank you very much, Dr. For giving us very incisive information and wonderful images. I think that forms for a very good library in some of our gadgets, something that we can easily refer to as we go about our other duties. So thank you very much for pointing that out. As we continue, I think I'm happy that a lot of our questions are getting answered in the Q&A box. If there are any that may remain as we conclude the presentations, we'll ensure that we answer as much as we can. Now, as you get to hear from the presentations, one of the things that is coming up is most of the patients that are having heavy bleeding are most likely to end up in theater for some intervention in one way or another. And when you have these challenges, administration of anesthesia is not a very straightforward situation. And so our next presentation is diving into theater to look at how do we administer anesthesia and what are the considerations in such kind of a crisis like in APH. So allow me to introduce our next presenter. Our next presenter is Dr. Leslie Gisare. Dr. Leslie is a consultant anesthesiologist currently practicing in the good county of Nairobi. For those of us who know the anatomy of this country, there are few hospitals that have, what I would call ni sifa yao Kikenya. And Pumwani has, one of the bragging rights as where we produce a lot of babies. And so I'm sure the team in Pumwani gets to see a lot of these complicated cases where administration of anesthesia in crisis when mothers are bleeding, all the times. So Dr. Leslie practices in Pumwani Maternity Hospital, and we'll be kind to hear from her just to take us through what are the considerations when we are giving anesthesia in such patients. Daktari, karibu, and let's hear from you.
Thank you so much, Dr. Odor. I hope I'm audible.
Yes, you're very audible, and we can also see the presentation.
Thank you. So I'll be taking us through anesthesia management of antepartum hemorrhage, something my colleagues have already discussed. And so those ones I'll brush through them, yeah? So next slide. So massive obstetric hemorrhage, of note when you look at those definitions, you'll have lost quite a bit of blood, yeah? And most of the times you'll end up losing about more than 35% of your blood volume, and which is important when it comes to shock recognition and categorization, yeah? Next slide. So we have to note that obstetric hemorrhage is different compared to other forms of hemorrhage. And this is because, one, you have the inability to recognize the risk factors. Why is this so? It is so because sometimes when a patient has presented with concealed placenta abruptio, the patient will not necessarily look like they're bleeding, but they're actually bleeding, yeah? The other thing, you have difficulty in exact blood loss estimation. Especially this happens in theater because the patient is bleeding and at the same time you have the blood being mixed with amniotic fluid, yeah? You also have difficulty in early diagnosis. This is because the normal physiology of a pregnant patient might mimic the physiology of someone who's bleeding. And usually the number one indicator of a bleeding patient or a patient in shock is tachycardia. And most women tend to have tachycardia in pregnancy. The other thing that makes obstetric hemorrhage different is the high uteroplacental blood flow. So the cardiac output that goes to the placenta is about 700 mils per minute. Yeah, let that sink in. So if you're bleeding from the placental bed, you can imagine how fast the patient can actually bleed out the entire blood volume. Next slide. So these are the common causes of antepartum hemorrhage. Dr. Grace has really delved into them. So the main issue with placenta abruptio is coagulation, and this we're going to talk about it. And the main issue with placenta previa, actually when you're thinking of anesthesia, is sorry. The main issue we're thinking about is the presentation of the patient. Yeah. So if this person you don't have a proper diagnosis beforehand, yeah, it can make it difficult for the entire team. Yeah. This is actually when the placenta is anterior, when the surgeon goes in to operate. The other thing that makes this difficult for all of us is when the placenta is low lying. Usually when the placenta lies within the normal fundal area, when you give oxytocin, you have proper contraction of the uterus, yeah? In the lower segment, the muscle layer of the uterus is less. So despite adequate contraction in the fundus, the lower segment may and continue bleeding, yeah? So these are the main challenges that comes with placenta previa for us who in anesthesia. And when we have that in mind, so even when you are giving general anesthesia for these patients, we have to note that our gases, our isopurine, our actually halothane, because it's halogenated, it will actually confirm more bleeding. So these are patients that you sit and think, if this patient is actually unstable, you might actually just maintain anesthesia with IV ketamine as opposed to gases so that you can be able to contract or prevent further bleeding from that area. Next slide. So pre-anesthetic evaluation. what is most important is to recognize and categorize these patients according to the risk factors. When you do that, you'll be able to know which patient you can get away with doing neural axio versus the patients that you have to administer general anesthesia, yeah? And with that comes adequate preparation, yeah? Because most of these patients, they are pregnant. You're thinking this patient has got a full stomach. There's a risk of aspiration. And also pregnant women tend to have difficult incubation, yeah? So you better have your plan A, B, C, D of difficult incubation algorithm, and as well to make sure that you don't have, or you've reduced your aspiration risk for these women. Investigations are important. Availability of whole blood and blood products, and that is why this is a teamwork. The lab needs to be aware. Recombinant human erythropoietin. This in facilities which is available, it's good to treat chronic anemia and that one refractory to treatment. Coagulopathies, when a patient already has thrombocytopenia or a coagulation factor deficiency such as von Willebrand's factor, thromboelastogram can be very helpful to diagnose and also to help in the treating modalities. And you can have patients on low molecular weight heparin. Thromboelastography can be used to determine use of neuroaxial anesthesia. Please note that when a patient has placenta previa, these are patients who may be admitted in the ward for a long duration of time and they're put on bed rest, yeah? And remember, pregnancy itself is a risk factor for developing deep venous thrombosis. So in such patients, you can opt not to give heparin.
Oh my God. Sorry.
You can opt to do compression stockings to actually decrease your risk for bleeding as well. Next slide. So shock recognition, yeah? How do you recognize shock? So this is an important slide, and during your own time, it's good to go through all of them. And of what is important is stage 3. Because when you're in stage 3, you'll have lost approximately 30 to 40% of your blood volume. And this kind of shock, it is not responsive to fluid therapy. And the fluid therapy, it's non-dextrose fluid, yeah? You can either give Ringer's lactate, normal saline, or colloids, yeah? And please note, you can give up to 3.5 liters, and after that, you start giving blood, yeah? And at this point, the patient might also need vasopressors to maintain our blood pressure at normal pressures. So we do not want anyone to reach stage 5 where the patient has completely exsanguinated the entire blood volume. Next slide. So resuscitation, it's good to categorize. Is it minor bleeding or massive bleeding? So even if you have placenta previa and the patient is not actively bleeding, you can actually get away with a spinal anesthesia. But why in doubt, general anesthesia is the way to go. When the patient is massively bleeding, you have to assess and access your airway, breathing, and circulation. Oxygen has to be given to the patient. So if the patient is in the ward and they're being brought to theater, you can put the patient on left lateral position and give oxygen as you're bringing to theater. So 2 large bore cannulas is important. And if you're in a facility that you can look for CVC access and even start your vasopressors there and then. Positioning, I've spoken about it. Keep the mother warm. With warm fluids, warm blood, and even warm blankets, yeah? This has been shown to actually help in PPH. Until blood is available, you start with IV fluids or colloids. Vasopressor requirements. The number 1 choice of vasopressor is phenylephrine, but most facilities, what we have is adrenaline and ephedrine. You can just start with what you have. As even when you're planning to refer, you can start with what you have. Recombinant factor 7A for those ones who are able to get it. Teamwork means you liaise early with the ICU team, whether the ICU team is in the facility or you need to refer the patient. And like I said, GA is a standard goal. You do rapid sequence induction because you want to avoid aspiration risk. You use cardiostable agents such as ketamine, etomidate if it's available. Volatile agents, you look and see the placenta previa, where was the placenta, was it low-lying, such that once the baby is delivered, you can actually switch off your gases and maintain on IV ketamine, yeah? And the need for vasopressor support. Next slide. So how do you monitor these patients? One, it has to be continuous, and you also have to document it, such that when you come later, you can actually see whether we are improving or we are not, yeah? And it also helps in auditing. So what are we looking at? We're looking at the color of the patient. We're looking at the urine output. Remember, urine output is 0.5 to 1 ml per kg per hour. So if the patient is, let's say, 60 kilos, and over 3 hours, they've only managed 90 mils of urine, then that's okay. You don't expect a 60-kilo patient to reach 500 mils of urine, Temperature, capillary refill. Capillary refill helps us to know the perfusion status of the patient. The blood that we have, is it going everywhere? Are we oxygenating every part of our body? So if our capillary refill is reduced, it means that we might start having ischemic changes. And one of the organs of concern is kidney, yeah? So we tend to have a lot of people developing AKI, post-resuscitation. And if it's not recognized and treated quickly, some of these women might end up with CKD as a lasting effect of resuscitation, yeah? Invasive blood pressure monitoring, it's important. If you don't have, it is okay. You can just do more regular and non-invasive monitoring. You can now monitor the patient either after every 1 minute, after every 3 minutes, yeah? So what are our targets? When we are giving blood, our target is to have a HB of 8 or more than 8. A platelet count should be more than 75. Prothrombin time should be less than 1.5 of the mean control, same as the activated prothrombin time. Fibrinogen level should be more than 1. And this is important. A TEG thromboelastography can help us know our fibrinogen levels, yeah? So what are the complications following resuscitation and whatnot? Of course, infection, still persistent anemia, maybe if you've not adequately replaced the blood, you may still be anemic even afterwards. Renal tubular necrosis, consumptive coagulopathy, getting into DIC, and this is more common in placenta abruption, PPH, prolonged hospital stay, psychological issues, complications of blood transfusion, fetal hypoxia or death, yeah? Next slide. So coagulopathy, it can either be as a result of the obstetric issue, such as abruption, or unknown bleeding disorder, and most often, maybe even undiagnosed, yeah? So when you have placenta abruption, it can trigger DIC by releasing massive amounts of tissue factor, thus activating clotting systems and consuming platelets, leading to hypofibrinogenemia. So fibrinogen levels is a vital monitoring tool in these ladies, yeah? And that is why when giving tranexamic acid, it actually helps in this because you're targeting this part of the coagulation cascade. So management, intraoperative cell salvage, it's important, but it's good to note when you've gotten into DIC, you've actually washing out the clotting factors, yeah? So even when you return this blood back to the body, you might not be able to form clots like the way you want to, yeah? Antifibrinolytic agents such as tranexamic acid, recombinant factor 7 can be given, but not in use when you have low fibrinogen levels and platelets. Cryoprecipitate is indicated when your fibrinogen level is less than 1. platelets and FFPs. This is according to the massive transfusion protocols that you have in your hospitals. The protocol is usually, it can either be 2:1 or 1:1. And you can either transfuse 2 packets of, or 2 units of packed RBCs to 1 unit of plasma. And plasma is 1 unit of platelets, 1 unit of fresh frozen plasma. Or you can do 1 packed red blood cells is to 1 FFPs is to 1 platelets. Next slide. So summary. It's important to classify and categorize the shock so that you know what you're dealing with and how aggressive you can be. 2, general anesthesia is the safest option when you're in doubt, yeah. But when you don't have active bleeding, the bleeding is minor, you can actually get away with a spinal anesthesia. Call for help. And this is a multidisciplinary team approach. Next slide. So those are my references. Thank you for taking time to listen. And I'll be answering questions in the chat box.
Thank you so much, Dr. Leslie, and also for the assurance, because I've seen a lot of questions were coming in even as we were presenting. So as we proceed, I know Dr. will be looking at some of them that have not yet been responded to as we continue answering your questions in the Q&A chat box. Thank you very much. Now, the next presentation for us, most of the times when we are taking care of the mother and you have such a case where you're having heavy bleeding, you've gone to theater, done things, and the mother just manages to survive, you are happy that, we've done something. Our next presenter brings in a different perspective to remind us of why this mother, first of all, became pregnant. When a woman becomes pregnant, the aim is usually not to just merely survive the pregnancy or the complications that come. The aim is that they're able to go home with a baby that is doing well. And so for the next session, allow me to welcome our next presenter. So our next presenter is a neonatologist, Dr. Mary Wayego. Dr. Wayego has been a neonatologist for about 10 years. And in the last 5 years, she has been at Kenyatta National Hospital, where she offers her expertise. And apart from treating the little ones, she also is a honorary lecturer at the University of Nairobi, where she is involved in neonatal quality improvement and focuses on initiatives that are focusing on infection prevention and optimal newborn nutrition. She's also a champion for kangaroo mother care. She's passionate about translating evidence into practical improvement in enhancing newborn care and outcomes. And so even as we look at this mother with heavy bleeding, it is my pleasure to welcome Dr. Mary to give us a few perspectives concerning the newborn. Dr. Nelson can help us have the presentation up. Thank you. Dr.
Evening.
Are you on?
Yes, good evening. Please confirm that you can hear me and you can see my slides.
Good evening. We can hear you loud and clear, and the slide is up. So take it away, Dr.
All right. Thank you, Dr. Odwor, for the introduction. And I am going to be representing the newborn, who is usually the hidden patient. I will not dwell on the APH background because the obstetrics colleagues have very ably discussed and described the presentation. I will go straight to what that means, the antepartum hemorrhage, what that means for the fetus. So for the neonate, what you're seeing in the mother can present in the form of early delivery, prematurity, the interruption of blood supply through bleeding or through abruptio or through placental separation results to hypoxia. And you can have that hypoxia presenting with hypoxic ischemic encephalopathy, but you can also have blood loss, blood coming directly from the fetus, and the baby presenting with anemia, or they can even present in shock. So the fetus is the hidden patient, and a lot of times there would already be compromise in the baby even before the symptoms become apparent in the mother. So early recognition of a baby who's demonstrating distress, timing the delivery optimally will usually alter your fetal outcomes so that the symptoms are recognized early and the method of delivery is chosen so that there is a optimization of the outcome of the mother, but as well as the outcome of the newborn. Oftentimes, like I've mentioned, the baby will already be in distress before the mother shows the signs. So, for example, a mother presenting with a concealed abruptio will already have significant hypoxia in the fetus and the newborn at presentation. So what effects does APH have on the fetus? APH has the effect of interrupting oxygen delivery. What that does is it causes fetal hypoxia, and fetal hypoxia will present in the newborn as a neurologic problem, presenting as hypoxic ischemic encephalopathy. Sometimes it can be so severe as to present as a stillbirth. The other effect that antepartum hemorrhage has on the fetus is early before term delivery. So the babies will present with prematurity, and that is accompanied by low birth weight in most instances. The fetus can also have bleeding, and you can have babies presenting with neonatal anemia and even presenting in hypovolemic shock. So it's important that these problems are anticipated. Once there's already activation that there's an antepartum hemorrhage, the system should also be activated to also wait in anticipation for a baby who will present with those effects that antepartum hemorrhage has on the fetus. So when we dwell onto each of the effects, starting with the prematurity. So prematurity presents early in the delivery room as respiratory distress syndrome. And those babies will presenting with, mothers presenting with APH, their babies are also at risk of respiratory distress syndrome, especially when they come in early. And this APH is one of the risk factors that presents a high-risk newborn at delivery. The other complication that we anticipate is necrotizing enterocolitis. And this is, again, common because as the hypoxia is presenting, sometimes when the babies come with anemia, and sometimes when they come in shock, their gut perfusion is also compromised, so putting them at even a higher risk for necrotizing enterocolitis than any other baby born without those complications. The other risk we worry about is intraventricular hemorrhage. And this again is high risk for babies born to mothers with APH because of blood pressure variations, and that presents that risk of intraventricular hemorrhage. Again, babies coming early are at risk of neonatal sepsis. Some of the conditions that come about with the antepartum hemorrhage would also be conditions that also put mothers and babies at risk for neonatal sepsis. Again, being born early means long stay in the newborn unit, and that comes with the risk of healthcare associated and hospital associated infections. So all those factors come in, and they are likely to complicate this baby who is born prematurely. So the balance is the timing of delivery, so that the baby is optimized while the mother is also stabilized, so that the outcomes for both are optimized. So we must always remember that even as we manage the mother, there is also a baby who is a hidden patient. The other complication that comes about from antepartum hemorrhage is a placental interruption, hypoxia, and that what we really worry about is also the brain injury. Abruption is, and this is a common pathway for neonatal encephalopathy. Chances are if a baby has hypoxia and it's a prolonged episode of hypoxia, the chances are higher that they are going to develop neonatal encephalopathy. And this is the causes of this are multifactorial. Number one, prematurity in itself is a risk factor. Number two, the hypoxia. And number three, the complications that come about from APH, and we've mentioned some of them in the form of intraventricular hemorrhage. So, and that means that because this baby will grow up into a child and an adult eventually, the risk of neurodevelopmental impairments are higher in this population. And there's been a question that has been asked about use of magnesium sulfate. So magnesium sulfate used in premature deliveries in mothers presenting in the imminent delivery below 32 weeks. It's always advised that they are given magnesium sulfate as a neuroprotective mechanism. This is what we are trying to minimize and avoid the end result of having babies with neurodevelopmental impairment, some of them ending up as babies with cerebral palsy. So this is the effect that giving magnesium sulfate has on these babies. Notice that way before the baby is born, the effects are already happening. So we say the best neonatal care, the best neonatal intensive care starts already before the baby is delivered. And these are some of the mechanisms that aid with that. So the other pathway in terms of the effect of APH on the fetus and the newborn is blood loss. So the abruptio, fetal maternal hemorrhage, vasa previa that has been elaborated can all result to neonatal anemia and babies presenting with shock. So how that is recognized, the baby will be pale. Usually babies are pink, tending towards polycythemia, but these babies will appear pale from the mucous membranes or even when you look at their skin. They will have pure perfusion that you demonstrate by looking at their cup refill time. They may also have metabolic acidosis for those that are able to do blood gases. And chances are when you find such a baby, you need to be prepared for transfusion. So as you're thinking about activating systems for blood transfusion for the mother, also have in mind that you're going to have a baby who will be compromised and who might also need blood product and most importantly packed red cell transfusion. So what do you do when you are in a facility that has been notified that there's an antepartum, there's a mother presenting with antepartum hemorrhage and is going to deliver? So delivery room preparedness is very important because these babies can come out fine, but more often than not, they will need some form of stabilization. So you do not want to be caught unawares with a baby presenting fast. They might be premature, but also even if they are term, they are likely to come out compromised. So for the delivery room preparedness, the ABCDs, the good old ABCDs still work. But for the newborn, we start with T, and T in this situation is talking about temperature. So hypothermia for the babies is a very big deal to the extent that the T appears before ABCD. So you always have to make sure that the area in which the baby is being delivered is warmed. So if you need to bring in additional heaters, you do that. The resuscitators should be set so that by the time the baby is being delivered, the linen for receiving are already pre-warmed, and the blanket and the mattress into which the baby is going to be placed is also pre-warmed. If you're anticipating a preterm delivery, also have a form of plastic wrap. There are some plastic commercially available plastic wraps, but you don't have to have those. There are units that use the paper that we use to wrap fruit. There are units that use paper that has been removed from consumables like fluids or like, so there are some consumables that are usually wrapped in plastic. So those can be useful and make sure that the receiving area is warm. The A is making sure that you have a way of clearing the airway for this baby in the form of suction. So test that before the baby comes out, confirm that is in the right suction pressures. If you don't have the suction equipment ready, make sure you have at least a way of clearing the airway. Penguin sucker is an option in some units, but have a way of making sure that the airway is cleared. For breathing, make sure you have a NAMBU bag that you have confirmed that it works. Have masks that fit, because sometimes you will have babies coming in premature. So you don't want a mask that is covering the entire face. It's not going to be effective. So you want a mask that covers the nose and the mouth. So have different sizes and a bag that has been confirmed to be working. Have a source of oxygen, because for preterm babies, chances are that you will have need for oxygen. In units that have continuous positive airway pressure, this is a good place to begin administering CPAP. So for units that are able to do that, please have that prepared so that you start it as soon as possible. For circulation, you need to have a way of getting an IV access. So have the right gauge of granules and lines. In units that can do quick umbilical catheterization, have that tray ready. In units that are not able to do that, at least have a way of getting an IV access. And and some fluids, some, glucose D10 in case the baby is noted to have hypoglycemia, some normal saline in case you need to administer that for blood pressure management, and a way of getting blood. So the system should have been activated that there is a baby who can likely need blood. And then for your medication, your D, we've talked about the fluids, we've talked about being in a position to do a blood sugar and managing if you find that it's low. And then chances of you needing medication are there, but they're not as much if you do your TABC well. But if you need to have adrenaline so that you can do your adrenaline administration in case you need to go that route when the heart rate is not responding. So if there is evidence of fetal distress, all systems must be ready to manage this baby. And the TABCD, you'll always go right with your TABCDs being ready. If there is anticipated blood loss, have a way of activating the system for you to be able to obtain blood as you need to. And then most importantly, you need to have a team that is dedicated to the baby. And I will pause there because oftentimes we have a team that is managing the baby and managing the bleeding, managing the blood pressures, but there is no one who has been designated that role of taking care of the baby. So you need an experienced and most importantly, somebody who is dedicated to just manage the baby without the additional roles of sorting out the mother as well. And that makes a difference. So once there is an APH alert, the neonatal team also need to be aware so that they can have what we've spoken about in terms of delivery room preparedness ready. So what other interventions are important? Antenatal corticosteroids when delivery is imminent. It has been shown to reduce your rates of respiratory distress syndrome severity, intraventricular hemorrhage, as well as necrotizing enterocolitis. Those complications that we spoke about to be likely to happen in these babies. So even if the mother is coming in and you quickly need to take them to theater or they are going to deliver in the next few hours, administering corticosteroids at that point is still very helpful. Of course, it's not optimal, but even towards the delivery, it still plays a role in protecting the baby. So if you're in a facility that you need to be referring, this is some of the medication that you can give even as you do your referral, so that by the time the mother is on the road, en route to where they need to get to, at least there's time for the corticosteroids to be doing their job of lung maturation. Where feasible, like in the case that was presented by Helen, in utero transfer is always better where feasible, because the uterus is in as much as there is the distress of fetal loss, of blood loss, it still forms the best transport incubator for this baby. So where feasible and where the risk is being measured and found to be in the right way, in utero transfer is always preferable. I've spoken about magnesium sulfate for all mothers presenting at 32 weeks and below, and the fetus has been found to be viable to have magnesium sulfate for neuroprotection to reduce the risk of these babies ending up with cerebral palsy, because already they are at risk of neurodevelopmental impairment. So it's always, as you're thinking about the mother and optimizing the mother, you're also thinking about optimizing timing of delivery for this baby. Remember that as you're taking care of the mother, as you're managing the shock, as you're managing the anemia, as you're managing the desaturations and oxygenation issues, that is also translating to the baby. So what I want us to remember, even as we manage the mother with APH, is that there is a hidden patient that you may not be able to see, and they have the placenta that we are talking about as their life support system. As you think about APH being an obstetric emergency, it's also a neonatal emergency, and whatever you're activating around the mother, you also need to think about the baby. The commonest pathway for neonatal adverse outcomes will usually be from early delivery in the form of prematurity and hypoxia, and optimized timely delivery, antenatal intervention that we've spoken about, and a multidisciplinary action will save the day and will improve the outcome of this baby that the mother so desired and presented to yourselves for care. So remember, best neonatal care often begins before birth. Thank you very much, and over to you, Dr. Odwor.
Thank you very much, Dr. Mary Makofi kwa Daktari, for bringing us a very incisive perspective about caring for the baby, the hidden patient that we rarely see at times when mothers present bleeding. I know we've taken a bit of time, but I want to assure you, you do not want to miss the next few minutes as we go into our next session of panel discussions. So the presentations have been wonderful to set stage for a very good evening of learning. The next session, we are going to have two panelists. If you checked our poster for the webinar, you realize that two of our facilitators or two of our specialists have not yet presented. So I want to introduce our first panelist, who I'm going to ask some questions that have been troubling me this evening as we listen to the presentation. So the panelist who is going to come first is Dr. Martin Sirengo Wafula. Dr. Sirengo wears many hats. First, he's an obstetrician gynecologist. On top of that, he's a public health policy practitioner and has amassed an experience over the last 25 years, spanning both clinical practice and public health and program administration. He's worked with the Ministry of Health and managed several programs, a number of them clinical programs, including the National PMTCT program, NASCOP. But apart from the clinical aspect, he's also managed the infrastructure department. He's also had experience in terms of intergovernmental relations and international health relations. It is these experiences that Dr. Sirengo brings in his current capacity as the director of the Kenya Blood Transfusion and Transplant Services. As you can see, Daktari has extensive experience in terms of what happens within most of our systems. So karibu sana, Dr. Sirengo. Let me hear your voice if you are in.
Thank you, Dr. Dor. I'm in. Please confirm if you can hear me.
Yes, I can hear you. So,
Thank you.
Daktari, thank you for joining us and for finding time in your busy schedule to be part of this webinar. I know you've been listening in from the beginning when we've had the other facilitators present. Now, something that has been mentioned severally is like you had Helen's case, a mother requiring a lot of transfusion. When the anesthetist is talking, need for transfusion, need for platelets, need for all these blood products. When the baby's doctor, Dr. Mary, was speaking, is when you have antepartum hemorrhage, then anticipate that even blood products for the baby will be needed. So the question I want to ask Dr. I'll pose two questions to you. Maybe I just request you can take a pen and note them down so that you respond to both of them together. Because I believe some of our participants are also asking themselves the same question. As the director of the blood transfusion and transplant services in the country, what are some of the measures that we've taken to ensure that every woman and every newborn who requires blood products have access to them? Because we've talked about need of these products, and some of our participants are coming from those very far to reach areas. They're just asking themselves, so if I need these blood products, what are some of the steps that the National Blood Transfusion and Transplant Services have put in place to ensure that all these patients have access? And number two, as frontline healthcare workers, what are they able to do at their facilities to support these efforts so that the mothers and the babies they're taking care of can have access to the blood products that they need? So, Daktari, I want to give you the floor to just share with us. Karibu sana.
Thank you, Dr. Dwar. Yes, you're right. I've been following the presentations from the beginning. And thank you for the opportunity to participate in this webinar. Of course, we all know that blood is very critical in attainment of universal health coverage. Besides its use in maternal and neonatal care, we need it in other cases, including surgeries, use for chronic diseases like cancer and so on. Now, as a directorate, we draw our mandate from the instruments that are there, both the Constitution of Kenya and the Health Act. If you look at Article 85 of the Health Act, it gives us the mandate to do what we do. Basically creating an outfit that manages blood transfusion services in this country. However, it's important to mention that this is a shared function. And because of that, conversations have been happening over time, and that led to the development of something called the Intergovernmental Framework for Coordination of Blood of 2022 that spells out the functions of the two different levels of government, including the shared functions. How are we organized to ensure that blood is available to all Kenyans? Currently, we run a WHO model, which is a hub and spoke model. The hubs being the regional blood transfusion centers that have the capacity to do blood screening and advanced testing for blood. And then the spokes are the satellite blood transfusion centers. So currently we have 7 regional blood transfusion centers, which are the hubs that are spread in the traditional 8 regions of Kenya, but I think 1 region is still missing. So we have Nakuru, we have Eldoret, Kisumu, Nairobi, Embu, Mombasa, and last 2 weeks ago, we added Garissa just to improve the availability of blood in that area. Of course, in addition to the 7 regional blood transfusion centers, every county has at least a blood satellite center, which has the capacity to do blood drives. They have the capacity, some of them, to do component preparations and distribution to the health facilities that we need. Currently, we have about 800 public health institutions that we call transfusing health facilities. If you add the privates, we have about 1,000. Of course, we can do better than that. Our wish is to ensure that at least every level 3B health facility, which is a basic obstetric facility, should be able to provide this service, and we have a long-term plan. So
for us to be able to provide blood, we just have to, make sure that all the components or the pillars of WHO are right. And Dr. Duor, I think the ultimate measure of availability of blood is when blood is available to the patient, whenever the patient needs it and wherever that patient needs it. For that to happen, our leadership and governance has to be right. Our health products have to be right. Our health financing have to be right. Our monitoring systems in terms of HMIS has to be right. And of course, things to do with human resource. So I would like just to quickly highlight some of the things in these categories, beginning with governance. We know that we have division of labor, as I've mentioned, and each of us have a very distinct role to perform. The national government, of course, being tasked with policies and guidelines, standards, and that's why we take care of the testing and capacity building of counties. And of course, the counties have the role of the service delivery, including conducting of blood drives. For us to do this, we need policies in place. We have been using a Kenya blood policy of 2002. I'm happy to report that now we have developed a draft policy 2026, which will be inviting stakeholders to participate, basically updating some of the things that we've done over the years that require updating. We have also a set of national algorithms and guidelines and standard operating procedures to guide the practice. Some of these are, of course, available on the ministry website. But in addition to these leadership and governance things, we also need to work with other partners, meaning that the ministry alone cannot do it alone. We collaborate with other partners at the national level. We have entered into MOUs with organizations at the Red Cross, St. John's Ambulance, and Chandaria Foundation for us to be able to carry out blood drives and testing. We also collaborate with individuals and individual organizations at the community level. Of course, Dr. Duor, sometimes we have a call for a rare blood group for a patient, especially the negative range, and we don't have it in stock in the place that the patient requires it. And therefore, that requires us to get in touch with these organized groups to get donors who are negative to give us the blood. The other thing that we have done to ensure that we have enough blood is to do planning and forecasting at the national level. However, this has been a bit weak at the county level because from our assessment, there seems to be suboptimal funding for blood at the county level to take care of the different things that we need to do. And as I said, if this funding is not available, it means that blood drives cannot be done. It means that certain commodities cannot be available, including the blood bank and so on, to collect blood. And so we have to continue the discussion to increase the funding for blood at both national and county level. And this has to be delivered, Dr. Duor, because unfortunately, when it comes to blood, our observation is we all start to look for blood when we need it. In that way, we're going to lose so many mothers and children and indeed other patients. Blood has to be planned. I think I've said this many times.
Yes.
The same way we plan for critical commodities, like magnesium sulfate, oxytocin, and so on, IV fluids. When we are doing the forecasting and quantification, it's important that blood is also at the table for discussion so that money is apportioned to ensure that blood drives happen to have adequate supplies of blood. The other thing that is important for us to provide blood in adequate amounts is our capacity to be able to prepare, not just for testing for infections like HIV, syphilis, hepatitis, and so on, but also to process blood in terms of components, and therefore facilities that our blood transfusion establishments need to up their game on this one. At the moment, we have a total of 50 blood establishment, and that's a combination of the regional blood centers and the satellites. Only half of those facilities are able to do components. And so when a clinician requires a specific component, say platelets, in a far-to-reach area, it becomes a challenge. And we're working with counties to make sure that we scale up this service. Of course, alongside the blood processing components, we have other specialized equipment like apheretic machines, which currently are only available at the regional blood transfusion centers because of the nature of this equipment. It's highly specialized, but it's important for clinicians to know that if you need an apheretic product, be it platelets or red blood cells, it's available at the regional blood centers. I'm impressed to know that Dr. Duor in your region, in Kisumu, Jaramogi Oginga Odinga has been able to do red cell exchange using the apheretic machine, of course, in partnership with one of the private health facility in Nairobi.
Yes.
But beyond that, it's important that the satellites, together with the counties, make sure that the satellite facilities are well equipped to collect blood, to process blood. In terms of just even a vehicle to do that, the human resource that is required, we have norms and standards for HR for satellites, which is a minimum of at least 8 healthcare workers, which is a combination of nurses and lab technicians. But we know that at the moment, the average is just like 3 or 4 healthcare workers in those establishments. And with the restricted funding, it becomes a tall order for us to be self-sufficient in having adequate blood. Of course, other things are important in terms of equipment, as simple as a cotton wool or disinfectant, a lancet, a blood pressure machines, all those things are important for collection of blood. And so I'll finish with a bit of a call to action for some of the things that we need to do. And I think that is captured in your second question of what healthcare workers can do. In terms of, in terms of health information systems, we have a national system called the DAM-KE that it's very robust. It's actually integrated to the National Digital Superhighway. It has the capacity to do all the functionalities for blood donation, processing, issuance, and the utilization of blood. The first part of that system, which we call vein 1 for blood donation, does very well. But when it comes to utilization of blood and blood products, we have a big challenge because blood is issued and we are struggling to have the healthcare workers or the people concerned to report adequately how we are using that blood. Of course, with the few reporting sites, we are about 65. We are able to do some analytics from that system. Yeah, so that is some of the highlights that I wanted to share with you, Daktari, on your first question. And then on your second question, what healthcare workers can do to support the National Blood Transfusion Service from where they are.
Yes.
They can do many things, Daktari. Number one is each one of us, be it clinicians or managers, we need to lead by example. We need to participate more in the planning, the same way we do forecasting and quantification for, HPTs. Blood is actually an essential HPT, and we really need to upscale its inclusion in the forecasting and quantification for HPTs, something that can ensure that at any given time we all have blood when we need it. Because when we look for blood and we expect the county blood coordinator or the laboratory person to produce it, and yet even the vehicle for blood collection is on stones, I think we are going to take a long time to get there. The other thing that I would like to talk about is for healthcare workers is we need to be aware that the blood transfusion science has changed over time. And it's important for us to be familiar with the current trends for rational use of blood. I always make fun of the old teaching that we used to have, where we used to write transfuse 1 or 2 with a 0 and a dot in the center, you know? So if you write such a prescription as a clinician and the patient requires packed red cells or platelets or FFPs, then we are not doing justice to the patient. The other recommendation I would like to make to all of us is to use data for decision making. This is quite important. I think every clinician, in this case, the obstetricians and pediatricians in your facility, do you know your annual blood consumption in your unit, so that as you work out with the blood coordinator or the lab in charge, you know how much blood you should be having on a monthly basis or a weekly basis. And then that can be computed against the minimum stock to ensure that blood is available all the time. My other recommendation is to involve the county blood coordinators in the inter-county MPDSR committees because they're left out most of the times. And yet, when blood is required, they're called upon to produce the blood and have no idea about what conversations go on in those meetings. I also recommend that all transfusing facilities to operationalize blood transfusion committees so that these committees have distinct roles and responsibilities as per the guidelines to run the business of blood. Hemovigilance is important. It's important, I know in the discussions from the different presenters, we've talked about transfusion complications a lot of times. It's important for us to be aware and prevent transfusion complications through hemovigilance activities. And we have a structured way of doing that. Maybe you can have that at another time. Second last, I just want to recommend that as counties or facilities that transfuse blood, we need to lead by example. We need to be proactive. It's not enough for us as clinicians to say we need blood at the time that we need it, and yet we give a blind eye in the planning for that same blood. I think as clinicians, given the position that we hold as obstetricians, gynecologists, or anesthetists, if we speak to the leadership of the county or the facility, I think they're bound to listen much more than anyone else. So we need to be part of those conversations. And lastly, we need to work with other partners. The private sector, where we fall short, I think we can invite them to come in, especially in taking up some of the roles like buying of refreshments for the blood drives and so on. So, Daktari, those are some of the reflections I would like to share regarding your two questions. Thank you.
Thank you very much, Dr. Sirengo. And as a consumer of blood products, one of the things I want to appreciate, Daktari, is the support that your department is doing. I think all of us can attest to increase of accessibility of blood and blood products where we are. And therefore, I really want to encourage us to reflect on what Daktari has shared with us, even at our level, knowing what the blood transfusion service is doing in terms of making the products available. What else can we do as providers to support so that this commodity is available? As we are coming to the end, I see some of the questions still pending, and some of my senior colleagues hoping to help us answer them live. So allow me to welcome our final facilitator of the evening before I go into that brief session of answering questions as we wrap it up. I can see time is really past. Our next facilitator, who is the final panelist for the evening, is Dr. Gerald Nganga. Dr. Gerald Nganga is a psychiatrist currently in Kiambu County. And Daktari, thank you for being with us this evening. We've looked or walked through managing a patient presenting with this obstetric emergency. At times, the outcomes are good. At times, they are good with certain complications. At times, they are not good at all. And I was just wondering, from your experience, because sometimes we don't see these complications coming back to us as the obstetricians or the midwives or clinicians who are taking care of the women directly. But from your experience in terms of mental health practice, what are some of the common psychological challenges that patients who survive and their relatives? I say patients who survive because, like the case Helen presented, a patient may survive and underwent a hysterectomy. That may have a bearing on how their well-being psychologically later. So what are some of the common challenges that you see for patients who survive these obstetric emergencies or even their relatives that you come across? And just also share what are some of the nuggets of wisdom you can share with us as the primary caregivers when they have these emergencies to make the burden lighter for them as we take care of them. So, Daktari Karibu, the floor is yours.
Thank you so much, Dr. Odur, for this very good presentation. It sparked a lot of memories from undergraduate. And, being a doctor is interesting. It's like riding a bike. Once you know it, the moment it continued, you start, familiarizing yourself with it.
Mm-hmm.
Now, yeah, that's a very interesting perspective of what was brought through, especially your question. Now, it is true that most of the times we get referral or consultation notes from the maternity section, postnatal, telling us that, oh, this mother is behaving funny and all that. Let me start by saying all psychiatric diagnoses are medical until proven otherwise. So, what does that mean? It means that by the time you're telling us the mother is acting funny, have we checked if she has anemia? Have we checked if she has electrolyte imbalances? Have we checked if something else happened? Babies are stolen, mothers die. There are a lot of things we hear from that side. So the first thing I normally ask is, yes, the mother may be behaving funny. Anesthetically, is she stable? Did she have any comorbidities before we are consulted? We have no problem coming, but because we are all doctors, so we can help each other solve that. So what do we normally expect? Most psychiatric conditions are postnatal. They're rarely prenatal because when they're pre, we see them in our clinics because pregnancy is a very high risk situation generally. Now, let me also add by saying that we have both psychiatric and what we call psychological issues. So things like stress, those are psychological. A patient needs counseling after all that. You find the mother is refusing to breastfeed, or even things as easy as maternal blues, which is usually within the first 2 weeks after delivery. These are psychological issues. You can talk to her, she has trauma and all that. Then we have psychiatric issues, which we're talking about things like postpartum depression, postpartum psychosis, and now in cases like APH, where you have maybe severe trauma, we've seen cases of a patient getting anxiety disorders. So not only is she anxious about herself and the condition, she's also anxious about the baby. If the baby will be well, if the baby will survive, because we know such emergencies, if not handled well, because we all worked in maternity as interns and MOs at some point. You get a child will develop delayed milestones, seizures, neonatal sepsis, all these kind of things. So you get the mother may be anxious, The relatives sometimes are even worse. We normally see on news, no one is sued more than gynecologists. Every issue that comes out is the gynecologist, and it's rarely the mother. You find it's the relatives who come and make all these complaints. Have we seen one case of PTSD? Yes, we have. Our mother had a very bad traumatic birth, and every time she'd see the baby, she'd start getting trauma. She sees the hospital, she's shaking, she has panic attacks, and all those kind of things. So when it comes to that, what is my advice? My fellow surgeons, we know sometimes these emergencies don't give us time. Plus, also, you may not go through the counseling session and all that and all that. But for the nurses, the maternity nurses, and the reproductive health clinical officers, I find they normally have time with these patients. They can brief them counseling. You see, between doing the GXMs, preparing for theater, and all that, a mother can be told that, hey, you know what, this is an emergency, these are the reasons. She's given a brief explanation. This may be the outcomes. This may not merely being given a consent form and being told, hey, sign for this. And the consent form has everything until a hysterectomy, but the mother has not been informed. We've seen that. Recently, we had a lady who had, I think, she had just given birth and a hysterectomy had to be done. I can't remember the indication of the CS, but there's nowhere she was ever told about that. She was young. We understand the surgeon was doing the best thing to save the patient's life. But a few 10 minutes, 15 minutes of counseling is important. The same also goes for postnatal. So once the CS has been done and before the patient is discharged, if they're stable enough, you can have a conversation with them and tell them that, hey, these are the things that can happen. These are the things you can look out for. If you start not sleeping at night, you're having nightmares, you're panicking every time, you start hearing voices and all that. And this can be done now with the relatives together because it's not that hard. The problem is that we jump without really taking our time. I'm not talking about a 45-minute counseling session. No, we're talking about 5-10 minutes to explain to them what to expect, what not to expect. The same way when you tell them symptoms of how it could be sepsis, also give them symptoms for their well-being, especially if someone is a first-time mother or even a repeat mother who's given birth normally several times and now has to undergo this emergency or elective CS due to APH, because the outcomes are very unpredictable after surgery. So for me, that is all I'll say. I feel time has passed a lot. I'm open to any questions that are there, unless there are any immediate questions right away.
Thank you very much, Daktari. It's one of those things that keep plaguing us, and for highlighting the need of proper communication. I think Helen also tried to emphasize that when they were doing their case presentation, which I think went a long way, but things that we need to really put into account. Now, our time is far much spent, but allow me to just take maybe a couple more minutes. One, let me welcome Dr. Wende. There was a question somebody was asking about the right volume to administer for purposes of volume fluid resuscitation when you are having massive obstetric hemorrhage and blood is not yet within the horizon. Maybe Dr. Wende, I can allow you respond to that as we pick maybe one or two burning questions as we bring this webinar to a close. So Dr. Wende, if you can unmute, karibu sana. Thank you for joining us and maybe just respond to that. We can't hear Daktari. I'm not sure. Okay. I see she's typed back. Nelson, is it something we can cure as we look into that? Maybe just a question I want to pose to Dr. Kakuti. Somebody has asked about use of tranexamic acid repeatedly in a pregnant woman, is it safe for our babies for us to use tranexamic acid in case we are having APH? Daktari, a comment from your end? Is Dr. Kakuti still with us?
Yes, I am.
Kindly, the question is it safe for us to use tranexamic acid in the pregnant woman before delivery?
Yes, you can. Yes, you can. I think I've not seen it in any guideline in terms of management of APH. But I think I wouldn't see anything wrong with there's no absolute contraindication that you can't use. I think I've heard of it being used, not personally. I've not seen it in any guideline, but I think maybe because it's not evidence based, if there's no literature on it. But I think push comes to shove, you may think about using it because maybe if you're considering a referral.
Thank you very much, Daktari. I don't know if Nelson is able to sort me. I wasn't able to get Dr. Wende's microphone on for a moment so that we bring this to a close.
Yes, seems like Dr. Owenda might have stepped away from her device.
Okay.
Yes.
Sawa sawa. Thank you very much, and apologies for eating into your dinner time to our lovely participants for keeping it with us and engaging us actively on our Q&A chat box. As promised, I can see we're already posting a lot of the presentations that were made this evening. I want to assure us that all of them will be made available so that we can continue revising and enriching our knowledge and responding better to our mothers and babies. As we've seen this evening, and this is what I want to be probably my parting shot for the evening, the kind of team that we need to respond to such an obstetric emergency, including the people that we don't always see readily every day. At times, you only see the midwife, the doctor, the obstetrician who is there in labor ward. You are not seeing the other people behind the scenes working in the lab, working in the transport department to handle logistics, working in the health maintenance unit to ensure that your appliances, your warmers are working well. So as we think about obstetric emergencies, let us think about a multidisciplinary approach. Hence the topic for today, a team-based approach to maternal and neonatal survival. If we miss anything else, let us pick that. The rest we can always revise and enrich our knowledge and ensure that anytime we are thinking emergency, let's not think, I want to die with this alone. Let's think, which team do I need to ensure that both my mother and baby are able to survive? Allow me to welcome again Dr. Lois, if you have any closing remarks so that we can all go for dinner. There's a question that has been asked, Dr. Lois. Si utupatie dinner. I hope you will answer that even as you make your closing remarks. Karibu, Daktari.
Thank you so much, Dr. Odwor. I could not be more proud of the team of panelists and facilitators and even our audience. And so I'm going to request our audience to help me appreciate our colleagues. Please use whichever emoji you fancy, whether it's clapping, whether it's a thumbs up or shamra shamra, naona love heart mumependwa. Thank you very, very much for taking us through what wamesoma. Even I have learned, kumbe, we no longer prescribe blood with kale kaziro na kadot. Asante for that. I do not have much more to add. I think our brains are full and our tummies are empty. Iyo dinner iko, we unaikula tu kwa roho. Just know I have willed to you a 5-course dinner in honor of today's learning. So let's maintain the focus on passing and sharing information about good maternal and newborn health outcomes. Imba wimbo ya Ewene, wherever you go, we want to save every mother and every newborn as we deliver our services. And look forward to the next webinar. It's also going to be as insightful as this one. And I hope that we can then, if you want to revise anything, look at the slides. And if you want to recap with this recording, please go to the KNH YouTube page, YouTube channel, and you'll find this webinar and others that have happened in the past. Shukrani, have a good night and stay safe. Back to you, moderator.
Thank you very much. And with that, we come to the close of our webinar today. Much appreciation to all of us. I wish you a lovely evening. Have some rest and let us wake up tomorrow energized and ready to save all our mothers and babies and ensure we deliver on the promise of Ewene. Good night.